Good evening, everyone. Welcome to Mahamana Case Discussion Series. And today we have with us Dr. Kaberi Kakati. She is a distinguished expert in the field of skull base, and she's going to deliver a talk on management of temporal bone malignancy. She's a professor in the Department of Head and Neck Surgical Oncology, B. Barua Institute of Oncology, Guwahati. Welcome, ma'am.
Thank you so much. Thank you so much for this opportunity, Sanana and her team. And thank you to Asimda also. I'll start my presentation. I just hope the screen is visible.
Yes, ma'am, it's visible.
So today's topic for discussion would be temporal bone malignancies. Before going to the temporal bone tumors, a brief anatomy overview of the lateral skull-based tumors, because it's a broader subgroup, broader group under which temporal bone malignancies happen. The lateral skull-based tumors are a rare group of disease which remains in close proximity to the various vital structures, and the route of spread is usually determined by this complex anatomy of the cranio-maxillofacial compartment, and it involves a highly specialized set of surgical procedures and has seen tremendous evolution in the last 20 years. The lateral skull base comprises of the following bones, that is the squamous and the mastoid portion of the temporal bone, the sphenoid bone, occipital, styloid process, and the zygomatic arch. This is a classification of the skull base by Irish and his team, where they had divided it into three regions. Region 1 mainly Region 1 is mainly the anterior skull base. Region 2 involves the infratemporal and the pterygopalatine area. And region 3 is, comprises of the temporal bone. So region 3 is the area where temporal bone malignancies happen, or it sort of gets involved by the surrounding areas. So region 3, as I said, involves the temporal bone with possible tumor extension to the middle as well as the posterior cranial fossa. Various vital structures can be found in this area, that is the internal jugular vein, the sigmoid sinus, and especially the lower cranial nerves. And the tumors in this area can be varied. It can extend from the congenital tumors, then inflammatory, traumatic, benign, or malignant tumors. So this is just the radiological feature of the version of the lateral skull base. So coming to temporal bone malignancies proper, they are a rare group of tumors with prevalence reported at just 1 per million. The ear canal and the temporal bone have various structures like the skin, the bone, the cartilage, the sebaceous glands, etc., which can give rise to tumors. So structures in the vicinity like the parotid gland, the mandible can also encroach the temporal bone. So the mean age group would be around 5th to 7th decade. The etiology of temporal bone malignancies is always an enigma, even if there is no clear-cut evidence on the etiology. However, the most two hypotheses for the cause for temporal bone malignancies would be the chronic otitis media. The reason being this chronic infection or irritation can give rise to malignancies. And second would be the exposure to radiation in the head and neck area for tumors like nasopharyngeal cancer or scalp tumors or lymphomas, etc., with a time gap between ranging from 5 to 20 years from the time of exposure to radiation in the head and neck area to the causation of the temporal bone malignancies. And the most common histology would be squamous cell carcinoma, as in any other head and neck tumors. So the route of spread would be the NT, because various critical structures lie nearby. So knowing the route of spread is important so as to chase the disease. The anterior spread can be to the temporomandibular joint, the glenoid fossa, ITF, and the parotid. Inferior can be to the stylomastoid foramen involving the facial nerve or the jugular foramen. Medially, it can involve the tympanic membrane if it is a ear canal tumor. Then can go further to involve the middle ear or the inner ear. Superiorly, it can spread to the to cause erosion of the tegmen and can extend to the middle cranial fossa. And posteriorly, it can go to the mastoid and then to the posterior cranial fossa. So this is the route of spread: anterior, superior, medial, inferior, etc. So the regional spread, the nodal metastasis at presentation is quite rare, that is less than 10%, and the primary echelon nodes would be the intraparotid nodes. However, nodal involvement is considered a bad prognostic factor with survival dropping by almost 50%. Distant spread, again, at presentation is very rare. So this is the staging system that we follow for temporal bone, because the temporal bone malignancies do not have a standard HSCC classification for staging. There are various other staging systems like the Moody's classification, the Cincinnati classification, but the most common staging system that we follow would be the modified Pittsburgh, where T1 tumors would be those limited to the ear canal without any bone erosion or soft tissue involvement. T2 would be those limited to the ear canal with partial thickness, partial bone erosion or soft tissue involvement less than 0.5. T3 would be those with full thickness ear canal involvement, bone erosion, with limited soft tissue involvement, or if the tumor has gone to the middle ear and mastoid. And T4, when it involves any other areas apart from the T1, T2, T3, like involving the cochlea, the petrous apex, the medial valve, the jugular foramen, the dura, etc. The disadvantage of the staging system is it does not differentiate between the good T4s and the bad T4s. So that is the sort of disadvantage of Pittsburgh staging system. So the N stage and the M stage is similar to the other staging system of head and neck. So the clinical features, the initial symptoms can be very vague, and they might just present with a ear mass or a discharge or a hearing loss. Advanced tumors might present with a facial palsy, vague fullness in and around the zygoma, temporal area or preauricular swelling, which might indicate the extension of the tumors. It can have a localized pain, trismus, indicating IKF involvement, or ataxia, change of voice, difficulty in swallowing and headache, which might indicate an intracranial involvement. So how to evaluate these tumors? History, as in any other cancer or any other disease, it is important to know about the condition. After a thorough history, a physical evaluation, which would involve the otoscopic examination, a thorough head and neck evaluation, audiometric evaluation, vestibular examination, speech and swallowing evaluation. Neurological examination is important because it stays in and around the vicinity of the nerves. And if in case we see that the tumor is in close vicinity with great vessels, and if we are contemplating surgery in that case, then it is important to have a vascular assessment in the form of a preoperative carotid artery assessment, like the balloon test occlusion, or a preoperative venogram, if we to know about the dominant venous system. Imaging, CCT for bony details, MR for soft tissue delineation. Usually CT scan, MR, we do both because it's sort of complementary, but CT scan is the initial diagnostic tool, HRCT, initial diagnostic tool. If we find that it is very early tumor, just involving the ear canal without much bony erosion, then probably sometimes we can do without an MR. But in all other cases where we see that there is some soft tissue involvement and we want to know the extent, it is always better to complement CT scan with an MR. PET-CT, even if it is not in the list of the initial diagnostic evaluation, but in advanced cases with too much morbid surgeries, it can be done. Usually, because the most common site of distal metastasis in head and neck as well as in temporal bone would be lung. If we do not do a PET scan, then HRCT thorax would also suffice. Advanced temporal bone malignancy with gross erosion and involvement of the posterior fossa. So the most common histology is already discussed, with squamous cell carcinoma, but the histology will also depend on the site of origin. If it is originating from the skin cancer, skin, and then involving the temporal bone, the histologies can be BCC melanoma or squamous cell carcinoma. Advanced parotid tumors would be having the parotid malignancy histologies. ITF tumors can be sarcomas also, and temporal bone, usually arising from the ear canal or the middle ear. They are mostly 80% of them would be squamous cell carcinomas, but we get other histologies also, like the adenoid cystic carcinoma. This is the algorithm for going ahead with the treatment, the first would be to assess the performance status and the disease status. If after the history, physical evaluation, and the radiological evaluation, we find that the patient can go ahead with a curative intent treatment, then the investigations would entail a pre-operative or a pre-chemoradiation workup. And the referrals would also have to be done in the form of audiological evaluation, speech and swallowing, and nutritional. If we decide for a palliative intent treatment, then it would also depend on the general condition. Poor general condition, probably only counseling and symptomatic care would be the treatment for the patient. But if it is a good GC, however, with advanced unresectable or a metastatic disease, then we can still go ahead with a palliative intent chemoradiation. But we should remember that skull base and same for the temporal bone malignancy management, it's a team approach which should include head and neck surgeons, neurosurgeons, plastic radiation oncologists, medical oncologists, pathologists, speech pathologists, etc. So it's a teamwork. So coming to the management proper, as in all other cancers, we have three modalities: surgery, radiotherapy, and chemotherapy. The goal of surgery is similar to any other cancer surgeries, that is to remove the disease, achieve negative margins, and to minimize the morbidity and mortality as far as possible. The surgical decision will again depend upon the site and the size of the lesion. Histologists also play an important role when we decide. Chemosensitive tumors like sarcomas, RMS, can probably go with a medical oncology management in the initial period, and accordingly. Exposure and access needed should also be decided, and degree of morbidity accepted to achieve the goal. But equally important would be a proper incision planning and an adequate surgical approach for the surgery, which would go a long way in reducing the post-operative morbidity of the patient. The surgical incisions and approaches. The first approach and incision would be a preauricular incision, where we can get access to the parotid tumors. For small tumors or for tumors usually involving the parotid and then encroaching the temporal bone, this incision can be used. But the post-auricular C incision is the workhorse incision for temporal bone malignancies, where we give the incision in the post-oral area. By this incision, we can get access to the temporal bone. We can elevate the pinna by disconnecting the ear canal from the pinna, and we can get access to the parotid. We can get access to the neck. We can get access to the middle cranial fossa. So this is the workhorse incision for any temporal bone malignancies, most of them. So again, there was an incision previously called the Y incision, where we used to give incision both post-oral or then pre-oral, so as to get access anteriorly to the parotid and the mandible, and post-oral for the mastoid and for the mastoidectomies. But this incision, as we give incision both in the post-oral area and the preauricular area, it cuts off the vascularity of the pinna, which comes from the superficial temporal system and the post-auricular arterial system. So this causes a necrosis of the pinna. It can cause a necrosis of the pinna. Hence, after the post-oral incision, where we can disconnect the ear canal and elevate the pinna anteriorly to expose the parotid, Y incision currently is not being used. So this is the post-oral incision with incision in the ear canal, also taking a good margin from the ear mass, expose the parotid so as to expose the mastoid, the neck, and if needed, the middle cranial fossa. So the next would be the fish incision, where usually it was designed by Hugo Fish, mainly done for advanced temporal bone tumors, pre-oral incision or post-oral, depending upon the access needed. The next would be the facial translocation approach, which was designed by Ivogenica. This is a modular design, and it gives great versatility and great access. And because of its modular design, the functional and the aesthetic outcome is also quite satisfactory. For the temporal bone tumors, we usually use the posterior extended facial translocation module. So the surgery for the temporal malignancies, it will depend on the extent of resection, which will again depend on the stage of the tumor and the extent. The three conventional temporal bone resection surgeries would be the lateral temporal bone, subtotal, and the total temporal bone resection. Lateral temporal bone is usually appropriate for a T1, T2 tumors conventionally. It includes resection of the ear canal, the tympanic membrane, malleus and incus, and the boundaries would include the medially the middle ear cavity and stapes, posteriorly the mastoid cavity, superiorly the epitympanum, anteriorly the TMJ capsule, and inferiorly the medial tympanic ring. Subtotal temporal bone resection conventionally was usually performed when there is invasion to the medial to the tympanic membrane, that is the middle ear or the mastoid, that is T3 disease. This includes LTBR, followed by additional dissection of the otic capsule and the medial bony wall. The boundaries would be posteriorly the sigmoid sinus, superiorly the middle fossa dura, anteriorly the internal carotid artery, inferiorly the jugular bulb, and medially the petrous apex. Total temporal bone is designed for T4 disease, which would include an STBR specimen with additional resection of the petrous apex, sigmoid sinus, jugular vein, internal carotid, dura, nerves are all removed if indicated. So it is usually associated with quite a significant morbidity without much survival outcome. So this was the LTBR. This is the subtotal temporal bone and the structures removed in that surgery. And this is the total temporal bone with the structures which is removed in a total temporal bone resection. So the treatment protocol, the lateral temporal bone resection is the minimum surgery that needs to be done in any temporal bone malignancies. There are concepts about sleeve resection for very small tumors. However, it is seen even in T1, T2 tumors, sleeve resection gives the recurrence rate is almost 40%. So the minimum surgery that we usually do is lateral temporal bone resection. In very small tumors, very superficial tumors, and with an indolent histology like adenoid cystic, sometimes probably we can do a sleeve resection, but this is not the usual protocol. The minimum surgery is always LTBR. So T1, the other treatment protocol, T1, a single modality treatment. So we usually go ahead with surgery. T2, surgery followed by adjuvant radiation. T3 and T4, surgery with a superficial prophylactic carotidectomy, provided it's a clinically N0 neck with level 2 sampling, followed by adjuvant therapy. Or if it is not surgically feasible, we also can go ahead with definitive chemoradiation in T3, T4 disease. So there is another concept of a piecemeal or a sequential resection versus the en bloc resection. As we have seen, a conventional STBR and a TTBR specimen or resection involves quite a considerable morbidity. So this concept of a sequential resection has come up, where we do a sequential removal of the tumor bit by bit, as if chasing the disease by continuous drilling till we get a healthy bone or until a negative margin is achieved. So there have been various studies for this. The study by Dean group and a recent study by the group of Mullman, where they have seen that en bloc resection versus sequential or piecemeal resection gives almost a similar outcome without, obviously with lesser morbidity in piecemeal resection. So resectable versus non-resectable. T1, T2, T3 tumors are obviously resectable. Among the T4 disease, there are a good T4 group and a bad T4 group. T4 diseases with quite a significant anterior extension involving the preauricular soft tissues, the temporomandibular joint, the parotid, they can be still operable. And so T4 with anterior extensions are a resectable disease. However, T4 disease with a significant posterior, medial, or a superior extension probably is not worthy to resect. It is not that we cannot resect, but the outcome, survival outcome, and the morbidities are quite significant, and the recurrence rate is quite significant. So probably they are not worthy to resect. Again, inner ear involvement, gross brain involvement, and metastatic disease would also come in that similar group. Management of neck. If it is a clinically N0 neck, there is no role of prophylactic neck dissection, except for a level 2 sampling probably, because it falls in the field of surgery. And if it is N+ neck, we do a modified neck dissection, especially involving 2, 3, 4, 5. 1B can also be done if 2 comes positive. However, as discussed, nodal metastasis is a bad prognostic factor with the survival dropping by almost 50%. Role of radiotherapy in a T1 disease, because if it's a single modality treatment, radiation can be given, but the studies have found better survival with surgery. But if surgically not feasible for some reasons, then radiation can also be an option. T2, T3, T4, usually surgery, best choice, followed by adjuvant therapy. In a T3, T4 disease, if in case surgery cannot be done, definitive chemoradiation can also be done, provided the GC is okay. And there have been studies where they have found almost similar survival between chemoradiation and surgery. But this survival data has not been replicated by other centers. However, that is also an option, chemoradiation, in case we can't do surgery. There is no standard chemotherapy regimen for temporal bone malignancies except for chemosensitive tumors like rhabdomyosarcomas. In some studies, TPF regimen has been used as a neoadjuvant agents, where they have found 50% cases being turning resectable, but this is still not the protocol, can be given from patient to patient basis, but this is not the standard for using neoadjuvant in temporal bone malignancies. Again, as said, if in case surgery not feasible, we can go ahead with a concurrent chemoradiation with TPF regimen. So the prognostic indicators would be the tumor histology again. Squamous cell carcinoma being an aggressive histology would have a bad prognosis than an indolent histology like adenoid cystic. Chemosensitive tumors would be having a good prognosis, etc. T1, T2 tumors versus T3, T4 tumors. T4 advanced tumors would have a bad prognosis, which is also being studied in the SEER database. Neck nodal metastasis, distal metastasis are a bad prognostic sign. Margin status, again, is a bad prognostic indicator. And pre-op facial nerve palsy is also a very bad prognostic indicator. And studies have shown that the survival drops from around 60% to 20% if the pre-op facial nerve is involved. So to conclude, temporal bone surgeries necessitates learning unfamiliar surgical anatomy and hence is technically challenging. Treatment decision is dictated by various factors like the site, the histology, and the extent of the disease. It's equally important to know when not to operate because these surgeries involve lots of morbidities, and all said and done, temporal bone tumor management is always a teamwork. Thank you so much.
Thank you, ma'am. That was a very good presentation. Now I request you to stay back and moderate the next session of case discussion. And today's case discussion will be done by Dr. Soumya Ji. She is a MCH resident from BBCI Guwahati. And the examiners for today are Dr. Ravi Shankar. He is Associate Professor in Neuro-Otology, Department of Neurosurgery, SGPGI, Lucknow. Dr. Harsh Dhar, he is a Senior Consultant, Head and Neck Surgical Oncology, Medical Oncology, Kolkata. And Dr. Ankit Mahwakar, he is a Senior Consultant, Head and Neck Surgical Oncology, HCG Cancer Center, Mumbai. Welcome, everyone. And before we go ahead with today's session, I would like to invite you all. I would like to invite you all for our upcoming masterclass in sentinel lymph node biopsy, which is on 25th. Are you all able to see?
Yes,
Yes, yeah. It's on 25th and 26th. On 26th, we have masterclass in sentinel lymph node biopsy. And on 25th and 26th, we have a workshop where sentinel lymph node biopsy technique will be demonstrated. I would invite all of you to register and participate. And masterclass is an online event. Thank you. Now, I think, Dr. Soumya, you can go ahead with the...
just a minute, Sunana. So
yes.
Once again, I just like to briefly elaborate because we have two sessions. One is a workshop that is on 25th. And for that, we just have only 8 participants. So whoever are interested and are willing to come to Varanasi, they are most welcome. And for the masterclass, we request all of you to please join. Thank you so much. You may please proceed with the session.
Dr. Soumya, you can share your screen.
Yes, ma'am. Good evening, ma'am. Am I audible?
Yes, you're audible.
So I've shared my screen. Is it visible, ma'am?
Yes, it's visible.
Good evening, respected teachers. Shall I proceed with my case presentation? Hello?
Please go ahead.
Yes, sir. So today I'm presenting a case of 62-year female resident of Guwahati, Assam, a homemaker, presented with chief complaints of bloodstained ear discharge from the left ear since 6 months and pain in the left ear since 4 months, along with a mass in the left ear since 4 months. History of presenting illness, she was apparently asymptomatic 6 months back. Then she developed a discharge which was insidious in onset, scanty, purulent, blood-stained, foul-smelling, continuous in nature. It was not relieved with oral medication or topical antibiotics. It was not aggravated with common cold, cough, and sore throat. She had a pain that is limited to the left ear since 4 months. It was dull-looking in nature, mild to moderate in intensity, continuous, not relieved with oral medication. It does not hamper her daily work or sleep. It was not aggravated with upper respiratory tract infection. She also noticed a mass which was initially small in size that proceeded to the present size to occlude the entire external auditory canal. It was associated with decreased hearing in the left ear since 4 months. It was gradual in onset, progressive in nature, non-fluctuating, not associated with ringing, sensation in ear, or jiggliness of the ear. Coming to the negative, there is a negative history. There is no history of post-oral swelling, fever, headache, vomiting, altered sensorium or vertigo. There was no facial asymmetry, no history of cough, hemoptysis, night sweat, loss of appetite, weight loss, or bone pain. She doesn't have any complaint on difficulty in swallowing, painful or decreased mouth opening. There is no neck swelling as well. Coming to past history, there was no past history of diabetes mellitus, hypertension, coronary artery disease, bronchial asthma, tuberculosis, malignancy, and surgical intervention in the past. There are no similar complaints in the past. There is no history of radiation exposure also. She had a history of taking over-the-counter medication for pain and topical ear drops for left ear discharge. She had normal sleep, appetite, bladder, and bowel habits. There is no history of any substance abuse. She attained her menopause 7 years back. There is no significant family history in the family. To summarize my history, she is a 62-year female, a homemaker, presented with complaints of blood-stained left ear discharge in 6 months, gradually progressive mass in the left ear since 4 months, which was associated with pain and hearing loss. So, shall I proceed with the examination part, sir?
So, Dr. Soumya, this is Dr. Ravi Shankar.
Yes, sir. Good evening, sir.
Good evening. So, from the history, what you are coming to that possible pathology, where is the possible site of pathology?
Yes, sir. So, I'm dealing with a female. She is a 62-year female with ear discharge. It can be a chronic suppurative otitis media with a oral polyp. And this is the infective cause. And one more likely condition will be a malignancy in the ear canal.
Okay. So, there is no history of the childhood ear discharge or no history of
No,
ear
sir.
surgery in the past.
No, sir.
So, but you mentioned about the swallowing difficulty, but you didn't mention about the speech pathologies, right? Any history of speech difficulty?
No, sir. She doesn't have any difficulty in speech also, sir.
So, why you are asking these histories? Why you are asking for the dysphagia, dysphonia?
Yes, sir. She has this 6 month long history. So any disease that is involving the lower cranial, the jugular foramen involvement, any complication of CSOM, any tumor of the involving the jugular foramen will lead to the lower cranial nerve involvement, leading to swallowing difficulty and change in voice, sir.
Okay, so there is a positive. You are ruling out the royal involvement.
Possibly, yes, sir.
So why you asked about the history, family history? There is no similarities in the family. Is there
Yes,
any
sir.
significance?
Sir, there are certain diseases that run in families like paragangiomas in the family. One more differential will be not directly the history of breast cancer patient in the family, sir. So breast cancer is known for metastasis to temporal bone also. To rule out this, I'll ask this condition, sir, the family history for parenchyma and cancer.
So the pertaining to the topic of interest today, so any other genetic conditions you know?
Sir, your pardon,
So
sir.
topic of interest is say a temporal bone, right? So any other genetic conditions associated with say a temporal bone?
So the paraganglioma, sir.
No. Even any epithelial malignancies.
Sir, you are not audible, sir. Not very clear.
Hello.
Yes, sir. Yes, sir.
Any genetic conditions that is associated with the epithelial malignancies?
Acute?
Epithelial malignancies like squamous cell carcinomas, basal cell carcinomas. Any genetic
Carcinoma.
condition?
Any
Skin.
genetic condition? Skin
Yeah.
condition, sir. Yes, sir.
Yeah, yeah.
There is, the pigment, sir.
Sorry? Xeroderma
Yes, sir.
pigmentosa.
Xeroderma pigmentosa, sir.
Okay, good. So what is the importance of history of radiation?
So radiation can be, so if the patient has received head and neck radiation like nasopharyngeal carcinoma and multiple myeloma for intracranial tumors, there is a chance of developing squamous cell carcinoma of the temporal bone.
Okay. So what is the usual latency period?
Sir, it can range from 5 years to 30 years, sir.
So suppose the pediatric, suppose the patient 20 year, the second or third decade presented with same temporal bone.
Yes, sir.
So in that case, what are the pathology you can suspect for the radiation?
Yes, sir. So in a pediatric patient who has
Received a RT, the first, then what are the pathology you can suspect?
this rhabdomyosarcoma, sir. And first differential in a pediatric patient who has received radiation is rhabdomyosarcoma, sir.
Okay.
Soumya, this is Harsh here. It's Dr. Harsh here. Any association with like CSOM or like a chronically discharging ear? Is there any association between that and the development of SCC of the temporal bone?
Yes, sir. It has been theorized that they have used this marginal ulcer pathophysiology in CSOM, chronic discharging ear, along with metaplastic changes, which is leading to squamous cell carcinoma of the middle ears.
Roughly what percentage of patients are likely to have this kind of an association?
Prolonged history of ear discharge, mostly a 2 decade, more than 20 years ear discharge, then presenting to us with mass, which was not responding to any kind of medication, sir.
Right. I was asking what percentage of squamous cell carcinoma of temporal bone patients may have an association with CSOM. If you talk about etiology wise, what percentage of patients will give this as a history? You can give me a round figure also, not to be exact.
So
If you
10 to
don't,
20,
10 to 20 is a very safe answer, right? So it's about 12 to 15%. Right. But do read up.
Yes.
Okay.
Yes.
I think if no further questions.
Dr. Ankit here.
Yeah, hi.
Yes. Yes, sir.
Hi. Can I ask one question, Harsh?
Yeah. Please, Ankit, please.
Hello.
Yes.
Hi.
Yeah, okay,
Sorry,
please go
I
ahead.
joined a bit late. I heard the history. By any chance, have you taken the history of any immunosuppression?
Yes, sir. She doesn't have any history of any kind of immunosuppression, sir.
Okay. And any profession, history of her profession?
History of sir?
Occupation.
There are two more etiological factors which are associated
Yes,
with
sir.
cancers of the external auditory canal.
Yes. Yes, sir. So
One
basically,
of them, if you're talking about basal cell carcinoma or squamous carcinomas, particularly about the pinna which extends into the external canal, is
Yes.
exposure to sun. So a
Yes.
profession which is requiring prolonged exposure to. Second is immunosuppression. If patient is a case of a transplant or on prolonged steroids or immunotherapy, in such patients, there is a risk, but it's small. But yes, there is a definite risk of developing squamous carcinomas of the external auditory canal. So all those rare carcinomas are much more commonly seen in those patients where the immunity is going on for a toss.
Yes.
Hello.
Yes, sir.
Uh, Dr. Soumya, what is the cause of a persistent ear pain?
So there can be a superadded bacterial infection. Again, the skin of EC is very sensitive to pain. So any infection infiltration of the mass can lead to pain in the ears. Sir.
What are the nerves responsible for this? You know.
Sir, superadded bacterial infection, sir.
So only the osteitis is the main cause. No, there is no neurological factor.
Yes, sir. Neurological, again, the spread of the tumor to the surrounding structure, neuronal structure involvement would lead to pain, sir.
Right. Okay, could proceed. I think if there is no more questions.
Yes, sir. Coming to general examination, the patient is conscious, cooperative, well-oriented to time, place, and person. The ego performance status is 0. She is moderately built, BMI of 23 kg per meter square. There is no pallid icterus, clubbing, cyanosis, generalized lymphadenopathy, or fetal edema. Vitals are 70 per minute, which is regular, right radial arm pulsation of set. Then blood pressure is 120, left arm supine position. Temperature is 97 degrees Fahrenheit, axillary temperature is taken. Respiratory rate is 18 per minute, abdominal thickness pattern of respiration. Coming to local examination, inspection of preauricular, pinna, post-auricular lesion appears to be normal. There is incidental finding of split ear lobule in the left ear. The external auditory canal, there is also proliferative growth, completely occluding the external auditory canal. The right ear canal appears to be normal. In the left ear, the tympanic membrane is not visualized, whereas in the right ear, it is intact. The mastoid region is normal in both the sides. So this is my inspectory finding. In the left side, there is a pinkish ulceroproliferative. Sir, hello.
No, you can proceed.
On of the left ear, there is a pinkish proliferative, ulceroproliferative mass with irregular margins, completely occluding the left ear canal. On palpation, the inspectory findings were confirmed. There is no local rise in temperature or tenderness over the mastoid in the preauricular region. There is no tragal tenderness in the mastoid, tragal tenderness or on the mastoid tenderness. On probing, the probe cannot be passed all around the tumor and it bleeds on touch. There is on tuning fork examination, Venus is negative, Weber localized to the left side. Absolute bone conduction test is equal. There is no nystagmus. Fistula test is negative. There is no facial asymmetry on examination, and other ENT and cranial nerve examinations were normal. There is no palpable neck node or parotid swelling on examination. The gait and vestibular functions are also within normal limits. To summarize, she is a 62-year female presented with complaints of blood-stained left ear discharge, along with mass associated with pain and hearing loss. On examination, there is also proliferated mass that bleeds on touch, and there is conductive hearing loss on examination. So my provisional diagnosis with the existing history and clinical examination is a left external auditory canal mass under evaluation, likely malignant cell.
Soumya, sorry if I missed, but did you talk about the neck examination and
Parotid
examination and the
Yes,
lower
sir.
cranial nerve examination? Did you mention
Yes,
that?
sir. Yes, sir.
Alright.
The parotid examination has been mentioned.
Okay. So all cranial nerves are intact and no neck nodes.
No, sir.
Great. So any of the examiners have any questions pertaining to the clinical examination part?
Soumya,
So,
Ms. Kaveri,
Yes, sir. Yes, sir.
why did you pinpoint to malignancy directly? Because there are various other diagnosis DDs of ear canal mass.
Yes, ma'am. So first is age. She is a 62-year female with a single episode of or ear discharge that has progressed over a period of 6 months, that has rapidly progressed to a certain extent that the mass is completely occluding the external auditory canal. That signifies the progression of disease within a span of 6 months. So with the age, with the progression of disease, it is more likely of a malignant origin rather than a benign origin. She doesn't have any previous history of CS1 in the past.
so in summary, you didn't mention about the amount of hearing loss. Is it important or not?
Yes, sir. I have done the pure tone audiometry, sir, but I have added it into the investigation part, sir.
No, even if you are tuning fork, you can get the amount of hearing loss, right?
Yes, sir.
So why it is important, amount of hearing loss?
Sir, we have to counsel the patient regarding the hearing rehabilitation. First is documentation of the hearing loss. We have to document it and the type of hearing loss and how much we have to counsel regarding the rehabilitation post surgery according to existing hearing loss. Again, the normal ear has to be evaluated to know whether the other ear is normal or not, sir.
Yes. So after clinical examination also, we can say that it's a moderate or severe kind of hearing loss from the tuning fork test.
Yes, sir.
Okay.
Yes, sir.
We're not going into the basics of it, but you must know the basic principles of a René's Weber's absolute bone conduction and and your fistula test. All of that. Just be abreast with it before your exams. In case some examiner wants to grill you on that,
Yes,
we'd
yes.
obviously want to discuss more regarding the management part, but that is something you should be well aware of.
Yes.
Okay. Right. So how will you proceed, Samya?
Yes, sir. So at this point of time, I will order some hematological investigation, radiological investigation, and audiometric assessment of the tumor along with the biopsy from the tumor mass.
Okay, what radiological investigations, obviously?
Yes, sir. So the first choice is high resolution computerized tomogram, sir, preferably a contrast enhanced CT, sir. Hello?
Can I ask one question, please?
Yes, sir. Yes, sir.
Would you like to take the patient in the OT or in a room where you can have a
Under
microscope and check?
Yes, sir. Yes, a microscope,
Yeah. And
examination under microscope, yes.
why do you think you need to do that?
So to see the mass all around, it is very evident the mass is coming out of the external auditory canal, sir.
Okay.
For disease mapping, sir.
Okay. And always, whenever you are saying this to the affected ear, na, for the
Yes,
sake of the examiner, please make a point that you examine the opposite ear and say that the opposite ear is absolutely fine.
yes.
Okay. And what kind of an audiometry would you like to do for this chap?
For this patient, the pure tone audiometry, sir, for documentation.
Okay. Documentation of what?
The hearing loss, the degree of hearing loss and type of hearing loss, sir. And the
Okay.
other ear also, whether it is.
Okay. Okay.
Hello, Dr.
Great.
Soumya. Hello.
Yes, sir.
So, in this case, you took the biopsy, it came negative, but you are suspecting strongly as suspicious of malignancy. And at the same time, you did the CT evidence of soft tissue density in the middle ear, mainly for sitting on the tumor sitting on the middle ear cleft. Okay.
Yes,
So,
sir.
how will you proceed? You go for the repeat biopsy or any other way to confirm the diagnosis? The disease centered on the middle ear.
So we'll go for the repeat biopsy, sir. Automicroscopy and biopsy.
So, any other investigations that is helpful? Do you think other than the biopsy? Interventional.
Yes, sir. Again, the radiological investigation are helpful, sir. I have initially I ordered a HRCT temporal bone, and again, a CE MRI will complement my diagnosis along with the
No, for
findings.
the biopsy part, the disease deeply situated lesions. Instead of going for the open biopsy, you can go for the CT guided FNS, right?
CT guided biopsy.
Yeah,
Yes, sir.
these are more appropriate than the
More specific. Yes, sir.
open approaches if you suspect a malignancy. Right. Okay, carry.
The biopsy has come out to be moderately differentiated squamous cell carcinoma, sir.
Okay.
So this is the HRCT temporal bone picture showing soft tissue and soft tissue density involving the left ear canal, completely involving the left ear canal, and there is sclerotic mastoid also. And this is the CMRI picture of the same patient.
No, hello, Soumya.
Yes, yes.
You have very important findings in the CT scan. You are not discussing about that, pertaining to the pathology. What
Yes,
is
sir,
happening on the upper row second cut? What is happening on the you can see the tympanic bone, anterior
yes, sir.
tympanic bone. What is happening there?
So there is bone erosion in the anterior of the tympanic bone with widening of the EAC. The
Is it
disease
important or not?
Yes, sir.
Okay, so then what is happening to the middle ear?
So there is no ossicles in the middle ear. There is soft tissue involving the middle ear, sir.
So there is a soft tissue density. It's very difficult to differentiate whether it's a middle ear fluid or
Yes.
pathology. But there is a
Yes.
fluid inside. Sorry, there is a soft tissue density in the middle ear.
Middle ear. Yes, sir.
So these are important, right?
Yes.
Why?
Sir.
Why?
So to differentiate the diagnosis, sir, to whether we're dealing with a disease or a infective etiology disease, sir.
No. It determine the staging, right?
To state the
Helpful in the staging or not?
Yes, sir. Yes, sir.
Okay. So, what is up other than the sclerotic mastoid? Any other anatomical importance in such a surgical point of view? What are the things you have to see? One is the sclerotic mastoid you have mentioned about it. What are the other things?
So the sclerotic mastoid means is the drilling, the extent of drilling we need to do, sir. If the air cells are less,
Now, what are other things you have to see here?
the low lying dura and the high jugular bulbs
Okay, then what about the sigmoid?
and the forward lying sigmoid, sir.
Okay. Then what about the facial recess?
So the internal carotid artery, sir.
Now, have you seen the facial recess, whether pneumatized or non-pneumatized?
So with the sclerotic mastoid, the relation of facial recess to it will be narrow, sir. In case of sclerotic mastoid, there will be no space.
Why it is important?
So the cordofacial angle, sir, for posterior tympanotomy approaches, This is the cortical angle where you need the muscular air cell renal pneumatics to operate in the posterior environment.
Okay. So what other things you have to see? Soft tissue involvement. One is the TM joint is involved, and there is a
TM
breach in the anterior canal. What other
Yes.
important areas you have to look for?
The superior extent of tegmen, sir, and the posteriorly the sigmoid, the sinus plate, anteriorly the medial and inferior involvement,
Pertaining to the facial nerve, coelomastoid foramen.
coelomastoid foramen, you have to trace the
That
coelomastoid canal, sir.
You have to see coelomastoid foramen also. If there is
Yes,
any
sir.
erosion or widening. But actually, the cuts are when you explain
Yes,
about the
sir.
CT temporal bone, you have to get the maximum sections, both coronal and axial sections, not only
Yes.
the axial. Okay.
Sir.
So in coronal axial section, we won't get the tegment,
Yes, sir.
whether it's low lying,
Yes, sir.
how it related to the ear canal, you won't get it. Okay?
Yes, sir.
And what about the carotid?
What about, sir? What about the
Carotid canal.
carotid canal, sir? Here it appears to be normal, sir.
What is the importance? So why
The
you have to
importance
see
is
that?
to check for the carotid this canal dehiscence, sir.
Yes.
The carotid may bulge into the middle ear, so
Hmm.
it's a carotid canal.
It's very important because most of the time our middle mesotomy is blind, right?
Yes.
So if you missed it, then it is a disaster. Okay. So there are these are certain important things you have to mention. Okay, and
Yes.
keep a habit of explaining from the beginning to superior to inferior or inferior to superior, whatever, sequential way, not randomly, and discuss the article status, discuss the facial nerve, tympanic segment, vertical segment, go in the order so you won't miss it any anatomical
Yes.
abnormalities, right? Good. Okay, carry on.
Yes, sir.
So Soumya, can you just use your cursor and show us where the carotid canal here is?
So this is the opening for the researching tube, sir. So
Right.
here my carotid.
Yeah, I think Dr. Ravi Shankar is more of an expert on this than me, but
So
yeah,
what
Ravi,
you
please guide her. Just say, I mean, just opine if she's correct or not. I mean,
so you are mark the initiation tube correctly. Just
yeah.
again the initiation tube is the carotid canal, right? You can that's the horizontal portion.
Okay, sir.
Okay.
Yes, sir.
Just anterior to the cochlea, you can see the basal tongue cochlea. Come, you
Just
can
come
see the
posterior a
cochlea,
little bit.
posterior. Come posterior. Point out your pointer.
Alright. Yes, sir.
Yeah.
Yeah.
So you are on the basal tongue actually. So in front of that, you can see the horizontal portion. Okay.
Okay, sir.
So whatever structures that Dr. Ravi Shankar was asking you on, whenever you're describing a CT or an MRI, any imaging, especially pertaining to a malignancy, you must describe obviously the extent of the pathology, but you must also touch upon the areas which we know, if involved, would make this inoperable. So it's important to mention about the carotid canal, the IAC, the jugular, the tegmen, as well as the anterior soft tissue, which is very evident here, and you skipped that in your initial, when you were just mentioning about the scans, you just went on to the MRI. But these are very glaring, obvious findings on your CT.
Yes, sir.
Right. Okay. So I think we can discuss the MR now.
Yes, sir.
Yeah.
This is a contrast enhanced MRI of temporal bone. This is the coronal section, and this is the axial section. This is a T2 wetted MRI showing the enhanced mass in the external auditory canal involving the middle ear. It is extending to the middle ear. This is the muscular air cells which are showing musculocytis features. And this is the condyle of the temporomandibular joint. This is the joint capsular lesion. And this is the bony wall in the posterior external auditory canal, which appears to be intact, and there is full thickness erosion here in the posterior canal wall. And in the coronal section, we can appreciate the bony erosion in the superior wall and extension of tumor above the middle ears. So this image
Dr.
also
Soumya,
was
this is not the way to present the MRI again. Okay,
yes.
so this is your presentation. So you have to go for a sequential way. First T1, what is the role of T1? What is the role of T2? What is the role of T1 contrast? What is the role of diffusion weighted? What is the role of ADC in malignancy? So you have to go in the sequence. First T1, and then T2, T1 contrast, and then special sequences. You are getting the random cuts, random sequences, and there is no continuity in the anatomy. So we are not going to get the information what we need, right?
Yes.
So what are the information you seek from the MRI?
The extent of disease, the soft tissue extension, involvement of the neural structure, the vascular structure, and
One is the soft tissue involvement pertaining to the. So okay, you can see one coronal section. I can see that, of course, there is no involvement of tegment, and I'm not able to see any parotid cuts here. Okay, so what is happening to the middle ear? From the cuts you provided, you can see that whether middle ear is spared or involved.
so there is extension to middle ear, sir, but the ossicles were not involved, sir.
So how come you differentiate the tumor from the middle ear fluids?
So the tumor will be iso-intense and the middle ear fluid will be hyper-intense, sir.
On
On
all
T1,
sequences?
yes, sir, on T1 weighted images, sir.
No. T1 or T2?
T2. So sorry, sir, T2 images.
Okay. Then how will you confirm that it's another way T1 contrast?
No, on
Okay.
T1 contrast, yes.
Okay. Then
Soumya, how did you mention that the ossicles are intact? Did you mention ossicles are intact? I thought I heard you saying ossicles are intact, or maybe I heard wrong.
no.
No, right?
No.
It's very difficult to decide. Even on the CT, I don't think we saw the ossicles well, and even on the MR, I think
Ossicles are
we
there,
don't.
but it's
Yeah,
partially disclosed.
yeah, I think it's they are involved. What about the petrous apex?
So it was, Petrus apex was not involved, sir, it was free. The patient has got her CT scans outside, sir. So these are the scans that are with her, sir.
So, Soumya, in the upper cut, first cut, what are the medial arrow pointing out? What is the anatomical location? Yeah, what is the anatomical location? What is this area?
So this is the middle ear, sir. This is the
Middle ear
extent
is
of
middle ear is a huge portion. Which part of the middle ear? And it's very important, and it's lying lateral to some vital structure. You can see the jugular bulb. So it's a hypotympanum. Okay, hypotympanum, and the bone lateral to the jugular bulb is intact. Okay, it's able to see or not? The arrow is obscuring the bone actually, so not involving the jugular bulb area. It's just reaching the middle ear. It's involving the middle ear, not eroding into the bone. Jugular bulb is intact. So what is the medial structure? That is hyperintense structure. What is that medial structure? You can see the cochlear, IAC cochlea. Right? So cochlea also not involved. We can see the bone coverage over the cochlea. The disease, why it is important? Is it make the difference in the staging or not?
Yes, sir. The inner ear involvement is a stage for disease, sir.
So
And
these are
inoperable.
inoperable. No, cochlear involvement is
Not
not inoperable.
worthy operating, sir.
No, it's actually you can easily differentiate the T3 from T4, right?
Yes, sir.
Okay. So what is happening to the soft tissue? Second row, first cut. There is soft tissue subcutaneous involvement also is there or not? Which area it
Yes.
is?
Which area, sir? It's a
Post-auricular groove.
post-auricular, yes, sir.
Yeah. There is some inflammation is there.
Yes, sir.
Okay. So what is the role of diffusion weighted? Is there any role of diffusion weighted imaging?
Yes, sir. It can differentiate between the inflammation and the tumor lesion, sir. So there will be more diffusion restriction in a tumor mass, and there will be less diffusion restriction with the inflammatory original mass.
Okay, so what is the role of ADC scores in this
The role of
pathology? ADC, you know ADC scores in diffusion weighted images from
the neoplastic. Again, the neoplastic and the inflammatory.
okay, so you can differentiate sometimes from benign pathologies from benign to malignant pathologies. So you can get a guess. It's not a confirmatory, but yes, of course, sometimes it's helpful. Okay, of course, diffusion weighted images differentiate the most common pathology, that is cholesteatoma. You can easily
Yes.
differentiate it. Okay, so,
Yes.
so if you see the smoothness within the ear canal. We have seen a cholesteatoma means what you call keratosis appearance, mimicking like a malignancy. We have encountered same like so. Only the diffusion weighted differentiated the initially we thought of malignancy, and we took the biopsy negative, and expansile lesion within the canal, same. And diffusion restriction, it showed a highly diffusion restriction lesion. So by the time the report came negative, and then we got it in an MRI, so we got it a keratosis appearance. So it means we need to see all the sequences, right, and read from the anterior to posterior to medial to lateral, whatever. Go through the section wise, okay, and follow one sequence and follow T1, T2, T1 contrast and special images. Keep the habit of it. Then, so it sometimes it will very helpful to differentiate the pathologies. Very okay. Yeah, please can.
So as the cuts are limited, so I have given this report was given. So this is a 32 lobulated enhancing lesion involving the left ear canal with full thickness erosion of anterior and superior wall of AC, minimal erosion of the posterior AC without extension of the mass into the medius mastoid cavity or the posterior cranial fossa. There is no ossicular erosion, no intracranial, dural, temporomandibular joint, styloid process involvement. No nodal enlargement in the pre-post auricular region. The inner ear was normal. On the right side, the AC, middle ear, and inner ear were normal. With this history and examination, my diagnosis will be a moderate differentiated squamous cell carcinoma of the left ESC with modified Pittsburgh staging of CT3 N0 M0.
Soumya, how much would you describe your anterior soft tissue involvement as? Because you have a proper breach of the tympanic bone, you have involvement of the TM joint. I think there is even some involvement of the TM joint capsule. So I'm not very sure this is just a simple T3. I believe the soft tissue involvement was more than half a centimeter. I mean, in my book, it would be a T4. I leave it to the other examiners also for their opinion based upon the imaging per se, because we have significant involvement in front of the EAC. What about Dr. Kaveri, Dr. Ravishankar, your opinions? I may stand corrected, but this was my opinion based on these scans.
So actually, in contrast, it's showing a lot of inflammation than the infiltration. Actually, there is no obvious breach on the T2 images on the condyle,
Right.
DM joint area. So,
But over here in the enhanced image, there is
yeah,
a good amount of soft tissue involvement in
yeah.
front of the,
Even the, yes, you
yeah,
can see
yeah,
that.
yeah. And I think even on the CT, if you can go back to the CT cut, Soumya.
Yes.
Yeah, here again, if you see the scalloping on the,
Yeah. Obvious erosion of tympanic bone.
yeah,
It's, full thickness erosion actually, no doubt.
yeah. So, well, I mean, I'd give it a second thought before labeling as a simple T3. We want to label it as a T4. So, yeah. And Soumya, in your summary, you've left out the middle ear of the left side. Left middle ear is involved. You said ossicles not eroded, but the middle ear space otherwise does seem involved. Yeah. So, what will be your management?
First, I will go for the counseling of the case of the patient. I will let the patient know what is the stage of the disease, extent of the disease, and need for surgery. So the first, I will go for this modified lateral temporal bone resection with superficial palpedectomy and level 2 samples.
What about the skin in the retromastoid region? There was some subcutaneous edema or subcutaneous stranding, I thought we saw on the MR.
Yeah, significant.
Yeah, it's quite significant. So I think those decisions have to be taken on table, right?
Yes, sir.
Yeah. Um, and what is your philosophy on managing or on inclusion of the parotid? Do you do it for all squamous cell temporal bones irrespective of the T stage, or are there any specific indications when you do a parotidectomy along with?
Yes, sir. It depends on the key stage of the disease, sir. So in T1, T2, if there is no radiological evidence of disease in the parotid, we don't go for superficial palpedectomy. But in cases of T3, T4 cases, we go for superficial palpedectomy, sir.
No. Even in T2s, is there any indication for
Yes, sir.
parotidectomy?
Involving the anterior canal wall, there is a role of superficial, considering the role of superficial palpedectomy, sir.
Yeah. So anterior inferior wall involvement and the erosion is more than 2 millimeter, and always consider for superficial parotidectomy. Right. Okay.
Soumya, what's your philosophy on whether you will do a lateral temporal bone resection or will you do a total temporal bone resection? Because we did see that the tumor was just abutting the cochlea in one of your scans. So to get a margin over there, don't you think a total temporal bone resection would give you better outcomes?
No, sir, we go for a modified lateral temporal bone resection, sir.
Sorry, modified?
Lateral temporal bone resections.
Modified lateral temporal bone dissection means you are following any specific classification or?
So this is a lateral temporal bone resection along with sequential drilling, chasing the disease bit by bit till we get the normal bones.
Okay.
Okay.
Okay. So actually there is a classification of lateral temporal bone dissection.
Macular,
No.
yes, sir, macular method, sir. Molar.
Right. Okay. So What is the difference between the subtotal and total temporal bone resections?
So in total, we remove the petrous apex, the total petrous, the internal carotid artery, and the sigmoiditis in total. So
In subtotal,
so we don't involve the petrous apex, because still the petrous and
in subtotal we don't remove the petrous apex. We remove only the
yes.
which part? RT capsule.
Yes.
Okay, so we remove the RT capsule, and we usually won't go beyond that. And as you said, internal carotid artery we preserve in that case. Okay. So what are the indications of neck dissections?
So if there is clinically N plus disease, sir, we'll go for the neck dissection, that is modified neck dissection level 1 to 5. And in case of T3, T4 disease, we'll go for level 2 sampling, but we'll get the note, we'll go for this neck dissection.
Okay. In prophylactic neck dissection, what are the lymph nodes you must remove? Suppose you are doing a prophylactic neck dissection, what are the lymph nodes you have to remove?
The parotid and level 2, 3, 4, sir.
Level 2, 3, 4 or level 2, 3 and 5A?
5A, number 5 is.
Not 4, it's 5A. If in a nodal positive, then you go for 4.
Yes.
Right?
Yes, sir.
So how will you determine whether the patient need a deep total parotidectomy or a superficial parotidectomy?
So if there is no radiological evidence of parotid node involvement, we'll go for a superficial parotidectomy. If there is clinical or radiological involvement of the parotid, we'll go for a total parotidectomy, that the facial nerve preserving if it is functional.
Yes. So at the time it's a on-table decision whether it's the deep lobe is involved or not. Then you can go ahead to sorry, okay. So how will you manage the facial nerve in these cases? The patient is normal facial nerve functions, and intraoperatively you are saying that the tumor is engulfing the xylomycete foramen and completely encasing the facial nerve. So how we are going to manage?
Sir, if it is functional nerve, we'll try to preserve the nerve, but even after clearing disease elsewhere, if the tumor is only limited to the facial nerve, we'll try to chase the disease to the second jelly. We'll transect the nerve and send the nerve for frozen section and put a cable graft for the transected nerve. If elsewhere it is 0, we'll go for the facial nerve sacrifice if the disease is there in the facial nerve. Is the last option, sacrifice the nerve.
When there is no frank involvement of the nerve, the normal function, we can preserve the nerve, right?
Yes, sir.
If there is a compromised function already, then there is no doubt you can go sacrifice. So what are the reconstructive options you have? Suppose if you sacrifice the nerve, what are the reconstruction options?
So we can put a cable graft, the greater auricular nerve graft. We have to put the static implant for transferopy and for the eye implants. Another nerve which is used as a cable graft is Surin nerve graft.
Okay. So this is a aged 65-year-old female. So what are the options you consider? You go for a neurotherapy or static procedures?
Or static procedures, but hearing.
Sorry?
Yes, sir, we'll go for the static procedures.
Okay, so not like that, but if you are able to able to preserve the normal facial nerve,
yes, sir,
normal facial stump, then you can go for a neurotomosis like a maxillary anastomosis or hypoglossal facial nerve anastomosis. But if there is no salvageable nerve, then of course in aged patients you can go for a static procedures. In younger patients you can move, more of neural reconstructions. We always prefer the neural reconstruction than younger patients. Older individuals usually go for a static procedures. Okay. Yeah.
just have a simple question, Soumya. When you're doing your LTBR and you know that you have to do a parotidectomy as well, do you unearth the mastoid portion of the facial first, or do you dissect out the extratemporal part first? Does it help in any way?
Yes, sir, we extend our incision, the post-auricular incision to the neck crease, from
Mhm.
where we set the level 2 area. We will identify the posterior digastric and the mastoid tip. From here, we can see the extratemporal branch of the facial nerve. It can give us an idea of the intratemporal course of the facial nerve also. So we can identify the facial nerve, the extratemporal part, the cerebromastoid and the digastric at the level of digastric. Then we can trace it upward for
Right. Also, when you're doing your final like a dislodgement of the temporal bone superstructure, when you're removing it, like once you've given your cuts, your epitympanium, your posterior cuts, when you're taking your final inferior cuts, it's always easy to have the extratemporal part of the facial nerve in vision. Otherwise, it may happen if that part is not dissected well, then you might end up injuring it as you take your final cuts towards the hypotympanium. This is just a small technical point that helps us.
It's very important actually. So when you go for an osteotomy, so we can safely do the osteotomy with if you have the facial nerve under vision, right?
yes.
What are the
Um,
what
no,
are
no,
the
please go
temporal
ahead.
bone? Sorry,
Yeah.
You can
No, no, please go ahead. Please go ahead. Please go ahead, Ravi. No worries. No worries.
What are the temporal bone anatomical landmarks for the facial nerve? When you drill out the temporal bone, cortical mastoid, what are the landmarks you look for to get the facial nerve?
So first it processes cochleariformis, sir.
Process is cochleariformis.
Short, yes, sir. Short process of incus. In the
Very good.
medial wall of the middle ear, there is the stapedius.
Sorry.
And so process of cochleariformis, short process of incus, and the digastric region, the mastoid.
Very good. Then other than most important, very easily identified landmark is the dome of lateral semicircular canal.
Yes.
Okay, so it is the most constant and easily identifiable. So you can't see the process cochleariformis in this case. Sharp process sometimes difficult, but the dome of lateral semicircular canal almost always findable. Okay, and then digastric is very good. The digastric groove also very important landmarks. How it related to the digastric groove? How the facial nerve is related?
So at the tip of the mastoid process, there is a group for the attachment of the muscles. Sir. So the facial nerve exits, so that will come in when to drill after doing the full cortical mastoidectomy.
So once you find the digastric groove, the facial nerve lies anterior and inferior.
Yes. Sir.
Okay, so that dome and digastric groove, these two are the most important and readily available anatomical landmarks that helps in the identification of facial nerve. So, okay.
How do you obliterate the cavity that you have created?
So we'll be using the local, the temporalis muscle flap and the sternocleidomastoid augmentation for the cavity closure in this case.
Okay, and what about your options for reconstruction? Suppose you've done a lateral temporal bone resection where you've had to sacrifice a large amount of your skin. In some cases, we also need to sacrifice a part of the pinna because if it's coming out of the EAC, the infrastructure of the pinna also may need to be resected. So you might have cases where you need a skin
Yes, sir.
cover as well.
Lovely.
So then what are your reconstruction options?
There are local reconstruction options and there'll be pre-flap options, so preferably the pre-flap like A and B. And the local options would be the pectoralis major myocutaneous flap, a spiral PMMC flap, a latissimus dorsal flap, and the submental flap, which is a local flap, submental flaps. The
Latus,
longitudinal
lat dorsi, I would not really quote here, especially in the presence of an intact PMMC. To get the lat dorsi that far up from the back of the, I mean, from its donor site up towards your temporal region, you might have to sacrifice a few fibers of the pectoralis major before you get that into the neck. So lat dorsi, I wouldn't really advise here, but definitely yes. Submental flap and pectoralis major are good options. If not, if you're
free
not, I
flap.
mean, if you're a free flap. Uh, any of the examiners have any other advice?
So, in that, Dr. Soumya,
Yes,
you
sir.
told about the temporalis muscle rotation, right?
Yes.
So, but in this case, you are planning to do the condylectomy probably, and the TM joint drill out. Okay. So, what is the extra precaution you have to do when you do this procedure, because you are keeping in mind you are going to use the temporalis muscle flap? What is the extra precaution you have to take care of during this procedure?
Sir, the internal maxillary artery, you have to careful for the internal maxillary artery, sir.
Okay, then
And the deep temporal branch.
very, very good.
Very good, very good.
So you should not injure the deep temporal vessels, okay? And then of course maxillary artery you have to take careful about the maxillary artery. Good.
Of course, you would be giving adjuvant radiation in this case. I think Dr. Kaveri has already mentioned this, but could you tell us about the treatment outcomes by giving upfront radiation for temporal bone cancers? Is there anything new that we should know of?
Sorry, sir. But in T3, T4 disease, if we give CTRT as a definitive therapy, so there will be survival outcomes are 53% and 43% in stage 3 and stage 4 disease. There is with surgery, it is 100% in case of T1 disease, sir. 80% in T2 disease, sir.
Okay. Any evolving role of particle beam or like proton therapy in these cases?
Yes, sir. Yes, sir. Proton beam therapy has been used, sir. But
Okay, there are some small series which give, progression-free survival as high as 60 to 70% with the proton beam therapy. And originally, proton therapy, although we talk about it now, but one of the very first proton centers was established in 1955, and that was at Harvard. And many of their initial series, they did offer radiation to patients with tumors in and around the skull base. So skull base is an area where proton therapy does have a role, even in the unresectable, inoperable select group. Of course, options in India is now limited, but from exam point of view, this is something that you should keep in the back of your mind to read up a few series, and if you find a meta-analysis, I think there are one or two. You should have a ballpark figure to be able to quote when asked in the exam. And another thing is that temporal bone resection is one of the favorite questions for surgical steps. You have a module where you have to describe a surgery. So I think lateral temporal bone resection is one of the favorite of all examiners. So you must know the steps, basic steps well, and you work at a center where a lot of skull base is done, so it shouldn't be too much of a problem for you. But for all those who are listening in, the residents, lateral temporal bone resection is one of the most commonly asked exam questions in your vivas. Uh, Anything further to be discussed? Dr. Kabiri, you can also please chip in. Ravi has been quite contributed excellently. Any other? Asim, you have a good share of experience from temporal bone, so you could also share a few key points. Ankit.
Nothing from my side. Very good questions and very good crossing of the of Soumya. She has learned a lot, I guess, and she also will be knowing what else to know in details regarding the temporal bone. She has been seeing cases, but just needs to sort of think it practically. But otherwise, all probably is covered except for the rehabilitation part, how to rehabilitate the hearing after
Yeah,
a
yeah.
temporal bone resection.
Yeah. Maybe you could add something on that. We kind of missed that, and maybe Ravi also might have more experience.
And for hearing rehabilitation, we can use bone anchored hearing aid devices.
So what is the precaution you have to take? What is the extra precautions?
So while raising the flap, prior taking the post-auricular flap, we have to mark the marking for the Baha. After that, we can take the incision.
Okay. So what is the
And
ideal
if
time for the
it
implant?
comes radiation, yes.
So what is the ideal time when you go for on the same sitting or second sitting or
Yes,
after
sir.
RT?
It can be a staged procedure or it can be a primary. We can anchor the Baha and it can add the procedure after 3 months and then again after completion of radiation therapy at 6 months for activations.
Okay. So ideally it's a same sitting and complete the RT
Yes, sir. Complete.
and activate the implant after 6 months.
Yes.
Okay. So you name me some implants. You know what are the implants currently available for this kind of cases?
Yeah.
Huh?
Audio. So not very sure. So audio, audio.
It's okay. It's okay. It's okay. So there are different companies, different names are available. Asia is from Cochlea and Bone Bridge from Metal. It's okay. And Baga, it's not an ideal for skull base, sorry, see tempered bone because it's a abutment is exposed and it's prone to infection and it's prone for osteomyelitis risk. The better is completely implantable implants like RCA or bone bridge. Okay, good. Hello,
Hello.
Yes.
Tarsh. Hello,
Yeah, this is Dr.
sir. Hello, sir. Asim, sir. Hello.
Yeah, please go ahead.
Yeah, it's okay, sir. I think we can finish. I think. Yes. Hello, Soumya. Are you?
Yes, sir.
Am I audible?
Yes, sir.
I think we can finish.
Yeah, Soumya, you presented well. Your clinical examination and your detailing for the history, more or less 80-85% on the spot. Definitely, you need to improve your reading of images and your presentation of the imaging. That I think with time and with more practice in your weekly classes, I think that should improve. Like Dr. Ravi said, there has to be a pattern, there has to be a sequence. We are all very much used to discussing an imaging of the oral malignancy or the neck or thyroid or even paranasal sinus. And I know that lateral temporal bone or mastoid tumors are not that commonly encountered, but we must know have a practice of how to describe these lesions as well. So because it is not routinely seen in the OPD, so it does not become at a spinal nature to you. So definitely spend some time in practicing this, and also read up about the surgery, read up about the rehabilitation, and I guess read up about etiology, because commercial is not the only pathology that occurs here. You must read about the paragangiomas, pediatric tumors, the various syndromes, all of that. So a lot of reading required here,
Yes.
and I'm sure you'll do very well. You work at a great center with great people to guide you. Ashok sir, Dr. Kabiri, Anupamda, and Rajyotida are all there. So I think just you know what to read now, and you need know what to improve. But overall, well done.
Thank you.
So Harsh, I just wanted to add something. See, the reason that we had this discussion on temporal bone was because this is a very neglected, and a lot of people just because the addition of the name malignancy, they start shying away from the responsibility of managing this tumor. It's very easy to manage, and we are going to have a lot of lot more discussions on temporal bone in future.
Yeah, great.
It's not very difficult. The most important thing is that we have to trace the,
Correct.
and that is what we have learned. That disease and resect it either en bloc or either piecemeal. But if you're able to get most important thing, like getting a lot of extensive diseases, tracing the disease and resecting en bloc or resecting piecemeal. However, this anatomy, the more we will discuss, everybody is going to and will be able to do it very easily. And as head neck surgeons, my aim is that everybody should do it. No base, it must goes to skull base. Skull base is a part of head and neck, and we must aim to get it and do it properly.
Correct. Absolutely. Well put, Asim. Asim, could you please share with us if you have any experience with neoadjuvant chemotherapy for borderline operable cases where the disease is very close to the
Yes, yes,
carotids or the IAC? What is
yes.
your experience?
So we do not have a proper set data about it, but what we are practicing is that suppose the disease that is touching the dura or involving the dura part of it, or diseases which is nearing the carotid, especially the diseases which are involving the parotid region and then going along the mastoid tip to the carotid, anterior diseases. Those diseases, they respond very well to neoadjuvant chemotherapy. This is what we have observed. And especially the anterior diseases, to those diseases, the part that is involving the parotid and the soft tissue, that shrinks, and that is very easy to excise later on. And the one that is dura, I think the Deepa madam has a dural protocol study that was started there in TMH. So those patients which are just near the dura or infiltrating dura, those respond very well to neoadjuvant chemotherapy, and then we are able to do a good resection for them. So that is a very important thing. So which diseases, and as I experienced in MPMMCC, what happened was that we initially did not have a neurosurgeon to cover us. So we were like very careful in selecting the cases, and then we found that the disease which is reaching till the dura, we gave neoadjuvant chemotherapy, and that it was very easy to do the resection later on, and the patient had a very good survival. Now we have to, we do not know how to put those data properly, but yes, it becomes, and there is a role of neoadjuvant chemotherapy. We just have to focus and get those resections done properly.
Great
So
points.
maybe what is your experience, Harsh? Like, where do you consider in borderline resectable? What is your borderline? Because borderline resectability sometimes also depends upon the skill and availability of the neurosurgeon. And majority of the things are like everybody has a good neurosurgeon and other teams available. And then we start thinking on the biology. But when we
Great.
do not have the availability of a surgeon, that is the time we start thinking. So what is your experience?
Correct. So I've been lucky enough to work with very good otologists at SSKM. But even then, as you said, anterior disease, which is nearing the horizontal part of the cochlea, we have been able to resect it quite well. Even in some cases, we've been able to drill the bone overlying the cochlea and have gotten good results. But any disease which is going posteriorly, inferiorly, and posteriorly towards the IAC, uh, we've not operated upon those cases. Obviously, because getting a neurosurgery backup and all of that was technically challenging. I do not have experience with neoadjuvant because either our cases have been operable or they have been, frank, outright inoperable cases. So, uh, really don't have much experience of NACT with the borderline operable. But I do understand what you said, that anterior soft tissue disease, definitely there is, and tumor proximity to the dura, there definitely would possibly be a role of neoadjuvant chemotherapy.
I would like opinion of Kaveri, because anterior soft tissue disease, because what we feel is the soft tissue disease will respond to neoadjuvant chemotherapy. And those are the diseases that may have a good outcome, especially when they are nearing carotid and we are not able to get a good margin. Kaveri, what is your opinion and what have you been practicing?
Dada, for anterior extension, anterior soft tissue, if it is upfront resectable, we are currently not sort of experimenting with
No,
any
even we are resecting those anterior upfront diseases. We are resecting. It's not like I'm saying at neoadjuvant chemotherapy. Only anterior diseases involving soft tissue and involving carotid or near carotid.
Yeah.
That
So
are the
we have
diseases
given.
that we send
Huh.
for
So our
RCT.
experience is very limited in NACT. We have given NACTs for, as you said, when the tumor is very much closer to the great vessels, the sigmoid, with that being the dominant system, and the near the carotids, and if it is an extensive involvement of the tegment dura. If it's a small involvement, we are resecting that, but it's an extensive involvement. We are trying, considering all other factors like a very good general condition, young patient, otherwise would be palliative. All those, if features are there, if factors are there,
Kaveri,
then we are
we have not.
experimenting with NACT. Otherwise, upfront
Okay.
resectable, we are still doing surgery upfront because response to NACT we don't know still. And in case it does not respond and it progresses, then we are in a mess. That's why.
Yes, no, I understand. So, I completely agree with you here that we do not know how much the response is going to be. So, whenever we are able to have a good, so my decisions for surgery, if a good patient in 50s with good and a small resection of dura is there, we are going to resect that part, close it with a tensor fasciolate or something, but we are going to resect it. But patients who are aged, and if we are able to give neoadjuvant chemotherapy, those are the patients we select. And anyways, we are having, I don't know, I've been lucky to get patients of temporal bone malignancy, all of them in their 60s. So we were taking those decisions. So I think that needs to work out. We need to figure out the data where we can give neoadjuvant chemotherapy in that. Hello, am I audible?
Yeah, please go ahead.
I think Sunana, if there's hello, yeah, was I audible? I was audible.
Yes,
Yeah.
very much.
Yeah. Okay, I think if there is no other comments, then we may conclude the session because these discussions can go on for ages if we just keep on discussing these gray zones.
So I add on one more point. The
Yeah, please tell
limited
me.
limited dural involvement is not a concern actually. Because I'm working with the neurosurgery department, it's
Yes,
easy for
yes,
us.
yes.
The major concern is the jugular bulb involvement. So when there is a jugular bulb involvement in, then it's a dilemma. So we have to go for the venography. We have to determine the most of the time. We have to determine the dominance of the venous, and few cases we end up with the complications like brain edema after resections. So when you deal with the jugular bulb involvement, you have to be more careful. Check your venous status of the venous drainage on the normal side, and then so that is extra one thing I want to highlight. The dural concern,
So
of
we
course,
have
less than.
slightly different experience. I wanted to add, good that you have brought this point out, because what happens is whenever we have this jugular bulb, I don't know I think Kaberi also can share her views on this, because we had 3 cases where we had the jugular bulb, because it's a limited diseases. So with the jugular bulb involvement, we have found that what we used to do is we start dissecting from the neck, trace it to the jugular part, and we had resected that part, and then we had plugged the entire jugular area. And we were able to resect it. That was the thing. And we keep the patient intubated for 3 days, and so that they have the chances of developing the collateral. So we were able to get away with that. I'm not sure what the experience of other people is and what the other neurosurgeons and the people suggest. So I think it will be better that we discuss these issues. But this is what we have been doing, like resecting it till the jugular bulb, plugging the entire area, and then getting away.
So, Dada, we
So-
have also done that, provided that is not the dominant venous system. So, if
Yes,
MR
yes.
veno does not show it as a dominant, we have also done that sigmoid sinus and jugular bulb resection if needed.
Yes. So like this is what, because jugular bulb is one of the areas everybody fears, like it's not going to increase the intracranial tension and everything. So we keep the patient intubated for 3 days, and then we are able to get a good resection. So we try to do that, because that also helps in forming the collaterals. Sunena, if there are no more comments, I think let's wind up the session.
Yes, with that, we would like to conclude. And thank you, everyone. It was a great discussion. And Soumya, you did well. And we'll meet again next time with a new topic and a new presenter and new set of examiners. Thank you, everyone.
Thank you.
Thank you.
And I would like to invite everyone once again for the masterclass in sentinel node biopsies. Those lucky 8 people who are interested for live sessions, they can come to Varanasi and join us. And for others, we have the masterclass online. Thank you, everyone.
Thank you. Thank you so much.
Thank you, Kaberi. Thank you, Harsh. And thank you, Ankit was not able to join completely, but thank you so much. And thank you, Dr.